Apologies for this.
Morning, everybody. Hopefully you can hear me.
We can, and we're live now.
Yep, so I've set, Claire's currently presenting and I've set the meeting live. Sorry for the technical difficulties this morning.
Good morning, everyone, to our board and to everybody watching this meeting today. Welcome to the public board meeting of Sherwood Forest Foundation Hospitals Trust. Would like to start with any apologies, any declarations of interest that we have. First, I'm not aware of any additional declarations of interest. Apologies for absence. I know that we've received apologies from Manjeet, from Tim, who is currently still in Tokyo with the Paralympics. I think those are the only two apologies I've received.
Yeah, they are, Claire.
Great, thank you very much. On to the minutes of the meeting held on the 5th of August. Read those as a true record. Any matters arising from them? Okay, on to the action log, and I think everything there is being picked up in our either being picked up on the agenda today or isn't due for action as yet. Chair's report, if I can take that as read, and I'm sure we'll come back to some comments at the end. This being your last public board meeting for Sherwood Forest Hospitals, and perhaps you'd like to, we'll move on to your Chief Executive's report if there are no questions on the chairs, and perhaps you can give us a few comments on your reflections of your time here as well at Sherwood Forest.
Morning everyone, thanks Chair for that introduction. So as normal over the last 18-19 months, Simon Barton, the Chief Operating Officer, is going to give a wider COVID update in a moment, and then Claire Teeney, the our HR Director, will be giving an update around COVID vaccinations. Without sort of stealing their thunder, it's clear that we continue to have COVID in our organisation and across our communities. And we were reflecting yesterday across the executive team about the importance of us all continuing to take personal responsibility to ensure our own safety, the safety of our patients and the safety of our colleagues. That involves balance between on-site working, off-site working, vaccination, social distancing, mask wearing, etc. And before I come to Simon, all I would say is I think it's possible to, and Simon will give us the exact details of the numbers of patients with COVID in our organisation. It feels that the numbers are relatively low when you compare them to the previous high points that we have seen at various points in the last year and a half. I think that hides, though, sort of some of the fragility in the organisation and the tiredness and the stress that many colleagues are facing at the moment. We know, as we will hear through the soft later, that we face across the wider NHS, including Sherwood, high levels of emergency pressures, and a massive effort is going into reducing our waiting times for elective cancer and diagnostic care. Wider agenda today at board in public, we've got maternity, we've got flu, we've got the workforce race equality standard, we've got our workforce disability standard, all incredibly important things. So I look forward to coming to those. And I also wanted to take the opportunity just to recognise all of our thoughts with everyone involved in the horrific events that we've seen playing out in Afghanistan over the last couple of weeks. We are working closely with colleagues across the public sector, across Nottinghamshire, and I'm really pleased that Nottingham City and the county have been able to rehouse and offer places of safety to families who have left Afghanistan at short notice. As the chair said, this is my last board. I've been at Sherwood for 4 years. I've been incredibly happy here, and I'm really grateful for the support that I've received. I felt very fortunate, probably about 4.5 years ago, to be offered the role at Sherwood, and I think on reflection I was very lucky with the timing that I had to join the organisation. Sherwood has been very good to me, and I'd like to thank Claire and Paul and board colleagues for their support. Many of you know me fairly well. Given my personality, it's inevitable that at times of privacy I will reflect on the many things that haven't gone well over the last 4 years, but equally I'm proud of the care that we've been able to provide to our patients and the way in which we've looked after people who work here. Life is not perfect, but Sherwood is, I believe, an excellent place to work and to receive care. And I'd finally just like to thank and to pay particular attention to the people, the many people at Sherwood who don't always get the thank and the recognition that they deserve. So people like Joe, who's a domestic on EAU, Chris and Mick, who are porters, Max, who's a phlebotomist on the wards and in outpatients. They're the people who keep this organisation ticking along. They're the people that have made Sherwood such a magnificent place it is, and Paul and Claire and others working with them, I'm absolutely certain will make Sherwood an even better place to work and to receive care in the future. So thank you all for your support. I've really enjoyed working with you, and I'm going to hand over to Simon to give a wider COVID update, and then Claire to talk about COVID vaccinations.
Thanks, Richard. So we do continue to be in wave 3 of COVID surge. We've got 40 inpatients today who are positive, positive being within 14 days of a positive result. So there are other patients in the organisation who are no longer counted as positive because they're beyond those 14 days. Critical care is the hardest hit area. They're currently in surge with 15 patients in ITU. Baseline capacity is 9. There are 9 COVID patients in there, and they're obviously under a lot of pressure at the moment across 3 geographical areas, and that is affecting some of our elective surgery. We are one of the highest surge units in the Midlands, and are regular users of what is termed mutual aid. So that is the transfer of patients between hospitals to make sure we have enough capacity to take another COVID patient inpatient. They're doing really well on the unit, and they're well supported, and there's regular contact between colleagues on there and the executive team through Dave, Julie and I. So we're really proud of the care that they're giving to COVID inpatients on ITU. The respiratory assessment unit is also in surge, so that is where COVID positive patients go directly from A&E to the respiratory wards. Likewise, they are under a lot of pressure, and are coping really well with the number of admissions they're getting. The rate in the community is about 470 per 100,000, which is very, very high. A bit lower than it was this time last month, but much higher than seen in any other COVID surge period, and consistently high as well. So it's been between 500 and 600 per 100,000 for the past couple of months. Yeah, admissions are 45% of what they've been seeing, excuse me, of what's been seen in winter 2021 surge. So we're seeing almost a double higher rate in the population, but almost half the rate of admissions. Patients who have been admitted are younger, and there are varying levels of vaccination of those patients. And Dave might want to comment a bit more on that. Workforce loss has been a real issue over the summer with regard to COVID isolation, compounded by normal sort of levels of sickness and annual leave, and that has really impacted on agency fill as well, and that has impacted on the organisation. It's been a Herculean task from everyone to make sure that everywhere is safely staffed, so well done to all the colleagues involved in just making sure there are enough colleagues to look after their patients on a daily basis. They're doing really well. There has been some easing of that over recent weeks because there was new national isolation risk assessment guidance which has been adopted within Sherwood and does allow some colleagues to come back to work once risk assessed if they're meeting a number of criteria such as they're double vaccinated. So that's quite promising for the future, given that we are likely to see further COVID surges over the next 6 months. So I'll hand over to Claire.
Thanks, Simon. Morning, everybody. Claire Teeney, Director of People. So we've got on the board report the regular update regarding the vaccination programme. Sherwood Forest colleagues continue to support the system-wide vaccination programme for COVID vaccinations. We've had over 119,000 citizens vaccinated through the hospital hub, and we support by hosting the resource hub, which provides the workforce for the rest of the vaccination programme across the county. We are still busy with phases 1 and 2, which was basically everybody over 16 that's eligible for a vaccination, along with health and care workers and those under 16 that are deemed as clinically extremely vulnerable. As is indicated in the report, we're now into the planning for phase 3 and hope to start the deployment of that later this month. Daily we are getting updates on guidance for that. Phase 3 will entail in the main booster jabs for everybody that was in the first cohorts that were vaccinated during the first few months in the winter, late last year and early this year. It will also include the vaccination of school children aged 12 to 15 years, and there are an estimated 47,000 children in that category across the county, and there'll be a prioritisation around offering the vaccinations to school-aged children as later on this month. Predominantly, that will be led by Notts Healthcare School and Immunisation and Vaccination team. However, it will be heavily supported by other colleagues across the county, and particularly with support from Sherwood Forest colleagues who have led on some of the clinically extremely vulnerable school-aged children vaccinations already. So they're really grateful for colleagues in supporting other teams to get up to speed with that, and particularly with support from the pharmacy team here at Sherwood into that programme around enabling the vaccination to be distributed to enable those children to be offered the vaccine. The final update this month is just to note that health and care home staff, it is mandated from November that those working in care homes do have to have a COVID vaccination. That's a statutory requirement, which is a change in the legislation. It also applies to those staff that may work into care homes. Our records suggest that we've got approximately 198 colleagues, either substantive and or bank, that may fall into that category. So we're just working through the details of that to work out who has and who hasn't had a vaccination, and to ensure that those vaccines are offered and prioritised to staff that may need to work in those categories. So I'll take the rest of the report as read in terms of it being here for assurance. Thanks.
Okay, do we have any questions to either Simon or?
Got Neil and Andy.
Yeah, Claire, thanks. Yeah, thanks for that report, Claire. Just wanted to ask about the phase 3 programme. My understanding is that no decision's been made nationally yet as to what to do about that. And I just wondered what the latest advice is from JCVI and if and when that programme is likely to start.
Thanks, Neil. So we haven't had the final specification or guidance through yet on that. We're anticipating that it will be a 1 jab booster, and we're not clear yet on whether that's the same vaccine or indeed a different vaccine can be offered. I don't know if Dave's heard anything in more, but we haven't got the final specification through yet, so we're just expecting that within the next few days, and it is due to commence at the end of September. The early signs were that it was due to start from next week, but it has been pushed back due to not having that guidance and now there is a prioritisation around the school-age children 12 to 15 to be vaccinated in the first instance this month.
So the only thing I'd add is that the study, the Cove Boost study, which I think I mentioned 2 or 3 months ago, is providing the data on the vaccination and the validity or the efficacy of that, and that data is still being interpreted. It was due to be completed in September, which is clearly we're only on the 2nd day. So there was a national announcement about boosters perhaps before the evidence was there to support it. So I think that's where we are.
Okay, thank you. Barbara, you had a question as well. I think Barbara was having some trouble with her. Oh, Barbara? If not, Andy, do you want to come on?
Claire, there wasn't a question from me, but you're right, I am having internet connection problems this morning. Apologies.
Andy.
Thanks, Claire. It's just a quick question for Dave and Simon. Can you give us an idea about the scale of the virtual ward? What support is it giving us and what support are we giving it, and how is it going to hold up in the coming months?
I can pick that one up, Andy. So the virtual ward at the moment has only got a few patients in it, so and it's still set up for COVID patients, but there's a plan within the within H2, which is the next 6 months of the year, which is mentioned in my report into private board later, to expand that significantly, and that's in line with national guidance and national reporting on that. We will be using nerve centres so our clinicians can monitor which patients are in those virtual wards, and then they can escalate and de-escalate those patients as they go. At the moment, we're sort of planning to have about 24 patients within that virtual ward at any one time, and a lot of that is being done in partnership with David Ainsworth and colleagues within primary care. We expect that to be up and running over the next month or two.
And just to add on that, so originally we set this up with the COVID patients, but we've now got an agreement with other patients that can fall into that facility, and we're utilising that as and when we identify those patients. It's quite interesting that a number of pregnant patients have been on virtual wards, certainly across the ICS, and I know to the south of the county they've got a whole virtual ward full of pregnant patients.
Okay, thank you. Any other questions? Thank you very much for that, the update. Richard, anything else you wanted to add at the end? Perhaps we can just, on behalf of the whole board, can we thank you for your contribution to this trust over the last 4.5 years. You've been a brilliant chief executive, and you really have stamped your own character and mark on this organisation. And I know that you will be missed, but we're really pleased for you and for the opportunities that moving across to Leicester will provide for you, and the contribution that you'll make to the NHS and to patient care across the Midlands. So thank you for everything that you've done. And I'm sure that we'll all across the board will have an opportunity to thank you individually as well over the next few weeks before you leave.
Thank you. Thank you, Claire.
Okay, moving now on to item 8, strategic objectives update, and it's over to Emma. You've got a report for us.
Thank you, Chair. So hello, I'm Emma Challens, the Director of Culture and Improvement. I shall take the paper as read, and I'd just like to highlight 3 to 4 areas that further provides a context and shaping of the paper. So this is with regards our strategic priorities over the next 6 months, which is H2 priorities, which is the second half of the year. So that's from the beginning of October up until the end of March 2022. The objectives and the priorities that you see in front of you are clearly aligned back to our 5 overarching strategic objectives as an organisation, which is within our strategy: healthy, healthier communities, outstanding care. So all of the priorities that we have set for the second half of this year align back to our 5 strategic priorities. We have undertaken quite an extensive engagement with colleagues across the organisation, both within clinical professionals, also leadership teams, and also through board development sessions. From that feedback and engagement, we've provided further assurance with regards our priorities for H2, which is about why are they important for Sherwood? How do they align and support our system partnerships, so across our integrated care system, and recognising those priorities? How will they be governed, both at a Sherwood and a system perspective? And then finally, providing further clarity with regards to measures for success. So what you have in front of you is our half-year priorities, the second half of the year from October to the end of March, that captures all of that further level of assurance in terms of why we're doing it, what we're doing, and how that is governed and assurance is provided. The final thing that I do want to say is that our underpinning subcommittee to the board and relevant executive groups will be the internal Sherwood Forest governance with regards progress and success against each of these priorities. I will pause there. I think that gives a summary of the actual priorities for H2. Thank you, Chair.
Thank you, Emma. Do we have any questions specifically on this so far? Okay, are we? We don't have any specific questions on it. I mean, you're asking us to endorse those priorities at the moment, and we would receive a quarterly update on this. Is that right?
That's correct, Chair. Yes.
Okay. I don't think we've got any questions there. Are the board happy to endorse this? I think, yep, I've got a question. Richard.
Thank you. So just coming off mute and covering my camera. It's always a shame when things are presented. I find this and there's no questions or comments. So I think it's a good piece of work. We went through it at execs yesterday. I think, as Emma was saying, there was a board workshop in which some of this was discussed, and hopefully those questions have been answered. I suppose my point is just really extending the point that the chair and Emma made, which is, in the absence of any response, do we feel that this is on track and will give us a good structure for where we want to go in the next 6 months? Because now's the time to say, if not. Okay. I think the IT system is being rather slow to update, because I'm seeing potentially maybe, I don't know if there's questions here, but there's certainly endorsement of what we've got, which I think the fact that we feel we have had an opportunity to discuss it in a workshop, Emma, and that there aren't any questions shows that this is a good paper, very concise, and very good links, as Andy Haynes has said in the chat, to the place and the system. So thank you very much. And if I can ask the rest of the board just to confirm their endorsement of this paper and strategy, please.
Thank you.
Thank you, Emma. Okay. Moving on then to item 9, strategic priority, and we're to provide outstanding care, and we're moving to Julie, who's going to take us through the maternity update.
Thank you very much. Good morning. There's 2 papers this morning for the board to review. The first one is the Perinatal Surveillance Scorecard. It looks better this month. You can see that we've had a reduction in the number of obstetric hemorrhages, and that coincides with our adoption of the care bundle that we updated on last month. We've also seen an improvement in FFT, and the team have started piloting the QR codes as well as the text messaging for that. APGAR of less than 7 at 5 remains amber, and we're just watching this. We think this might be attributed to a learning package that came out following a coroner's case where it was felt that we overestimated the APGAR score. We haven't found any themes or concerns in that, and there's no incidents been reported externally from that perspective. There were 2 temporary closures during the month of July, and that was attributed to the acuity of women and the staffing being unable to meet any further demands. So there were temporary suspensions with diverts to local units. From a maternity safety champions perspective, the things I just want to highlight are that the number of women booked on a continuity of care pathway fell to 18% in month, with 0 receiving continuity of care in the interpartum period. You'll recall that last month I advised that we'd agreed a pause in that programme of work following the evaluation that showed that actually the model wasn't really providing enhanced continuity and the working patterns were unworkable for the midwifery teams. We are restarting the new model that's been developed in collaboration with midwives later this month, but board can expect this to deteriorate for the next month and should see an improvement in November. We've continued the safety champions walkarounds, and we've done a virtual maternity forum as well. We've received positive feedback around the changes that we've made to staffing within the acute maternity service. We had some concerns highlighted around the antenatal care pathway and just an increase in women being seen, and the teams have put some clear actions in place to increase capacity for a small number of women that are now choosing to have their babies at Sherwood. The Ockenden submission and the NHSR returns, there's no update on that. We're still awaiting national feedback for that. There's no incidents that have been reported externally either in month. And board asked me to take away an action to look at developing a maternity assurance programme at Sherwood, just learning from some of the CQC reports we've seen in maternity elsewhere. That programme has been approved by the Maternity Assurance Committee and the executive team, and it's there for your information, but it focuses around data and information, listening to people, and then observations both at Sherwood and externally. Very happy to take any questions.
Thank you, Julie. I would also endorse what you said in relation to the maternity safety champions walkarounds. And I think that the frequent visits that we have onto maternity is encouraging staff to talk to us and to open up a bit more about some of those concerns and allowing us to work on addressing those, particularly, as you said, the last visit raised the issues around the pressures in antenatal. So I'm really pleased that that's being done. So thank you for that. We do have a question from Barbara.
Thanks very much, Julie. Just really wanted to pick up on the paper around this. I think it comes under the Saving Baby Lives Care Bundle. The comment that you'd had feedback from the Midlands Maternity Clinical Network and the CCG about a couple of areas where we're deviant from in terms of the action plan, just to sort of understand what the implications of that are.
It's around our scanning protocol. So we had some derogations from the national protocol that we'll now have to implement. So it does mean additional measurements that need to be done during the antenatal scanning. Our sonographers are trained, but it will require the duration of the scan to be longer ultimately. And the team have put a plan in place for that to happen and for us to have appropriate referral pathways if abnormalities are found.
So has that change now been agreed with the MCN?
We've received formal notice and we've got time to implement.
Okay, great. Thank you very much indeed.
Thank you. Question from Andy.
Thanks, Claire. Hi, Julie. Just a quickie. So I think the maternity assurance programme is excellent and that's really good. So we'll look forward to updates from that in the future. Can you just update us on section rates? It's not on the dashboard, but just we've not historically had an issue there, but I just wondered where we are with emergency and elective section rates.
So the section rate is consistently equaling around 30% for elective and emergency. It is slowly creeping up. It's not, lots of the concern is around whether it's too low, and we have agreed to add this onto this perinatal surveillance scorecard, so I'll make sure that that goes on for next month.
Great.
I lost him.
Andy?
Yeah, no, I'm still here. Some strange messages come up saying you're live, but you're muted. Sure. So there you go. No, that's really good. That's helpful, Julie. Thank you.
Thank you.
Great. Thank you very much for that. No other questions. We will move on to item 10, strategic priority 2, and we have a paper on flu update. So over to Claire, I think.
That's right. Thank
Lovely.
you. Thanks, Claire. Yeah, so the paper is here to provide assurance to the board that we are on track to deliver our annual flu programme and campaign for our colleagues. The details are in the report. It is expected that we may see a rise in flu this year, and also that there might be an earlier onset. So we are prepared for that. Everything is in place to start to deliver the flu vaccination programme. We commenced in the 20th of September through pop-up clinics, occupational health and a peer vaccination programme. We aim to offer 100% of frontline workers the vaccination, with an expectation that we will achieve a target of around 85%. We are confident around that. Last year we achieved over 87% of frontline health and care workers in terms of the uptake of flu. And as is detailed in the report, the uptake each year over the last 5 years has increased. So we have got a solid and robust offer. Last year we also saw a real early uptake of the flu vaccination, and so we are prepared and also hopeful of that this year. So the report is here for assurance that we're in a position to start and commence that programme later this month.
Thank you, Claire. Perhaps I can ask, how will this sit with the booster programme that you outlined earlier, given that obviously some of our staff will be entitled to a booster vaccination on COVID, but also a flu vaccination. So are we comfortable that those will be taking place potentially on the same day, at the same time? You know, are we utilising the resources and collaborating across the two services?
Yeah, thanks, Claire. So we're waiting again for further guidance on the administration of both of the vaccines. The talk now is about co-promotion around update rather than co-delivery. So we're not clear on the final spec, but we are confident that we will have a good offer for both vaccinations for all of our colleagues, and we remain agile to be able to adjust should there be changes in that guidance once both programmes commence later this month. So we think we're in a really good position to be able to support the delivery and access of both, just pending further details to come down on what we can actually do, and we'll make sure that colleagues are well aware of the parameters around that as soon as we get all of that information.
Okay, and we've got sufficient time in terms of planning, given that we're receiving guidance quite late to be able to do this, because obviously I assume that this means we're going to have double resources of staffing in order to deliver both aspects of the flu and the COVID booster.
Yeah, so we're confident that we can offer both. The flu vaccination is delivered mainly through occupational health and through peer vaccinators, so people working into the wards and clinical areas that are staff on those wards. The hospital hub to offer the COVID vaccination is where colleagues will go to receive that vaccine, and that has been staffed throughout with additional staff and we continue to staff that in that way. Given that we run the resourcing hub for the whole vaccination programme for Nottinghamshire, we're also confident that we've got sufficient staff to be able to support the delivery of both for us here at Sherwood and more widely. The other thing that I should just add in that I didn't mention on the early report is that throughout phase 1 and 2 for COVID vaccinations, we have been supporting 9 vaccination centres. They will consolidate to 2 hospital hubs and 2 vaccination centres, so the staffing requirements into those will be reduced and we'll be able to utilise those trained colleagues in a number of other ways. So I think it puts us in a good place.
That's very helpful. Thank you, Claire. Got a question from Andy.
Thanks, Claire. Claire, so our record on staff vaccination has been good, and as you've demonstrated in the paper, been increasing, so I think that's brilliant. The response for patients in the community probably has been lagged behind that a bit over the last 5 years. I just wondered where we are with that community response. I think we did quite well on care homes last year, but obviously in the light of the winter that we think is coming, some assurance around that system programme will be quite helpful.
Yeah, I can bring some further details through on the delivery of that. The flu vaccination programme will be delivered across the system in the same way that it has done it has happened in other years. We are hopeful that there will be a bit more of an encouraged response from the population more generally, and then there has been in previous years, noting the promotion that there's been more widely about the importance and uptakes of vaccinations across the board. So that, Andy, will be delivered in the same way across Nottinghamshire, largely through primary care and through local pharmacies and PCN networks. We won't, other than for some patient groups, be playing any wider role in terms of our hospital delivery than we have done in other years around flu. I think Dave's got a comment on that as well.
Well, I was just going to add a couple of points. So in terms of our inpatients, we've suggested groups of inpatients who we think that we might be able to vaccinate while they're with us. It's relatively low numbers, and that's gone into our numbers of allocated vaccines. There are specific groups that we do target that Andy will be familiar. So we had very good success rate with our antenatal clinics and our patients attending our renal dialysis unit. In terms of the greater visibility across the system, what is also happening is that there's a move to put flu vaccination entirely onto a national data capture system, and so I think there will be increased visibility of which of our patients, which of our members of staff have had vaccination elsewhere, and that may help with some of that, recognising that doesn't really impact on the wider system patient. It does perhaps give us the opportunity to have greater visibility of our staff metrics.
Thank you. Claire, you wanted to come back in on that too?
Yeah, it's just a final comment really on some of the wider system uptake around flu. One of the things that we have been working on are some of the lessons learned. So particularly from offering COVID vaccinations, what's worked and what hasn't. And one of the things that has tended to work very well is where we've had pop-up clinics and citizens have been able just to walk in and get their vaccination. And for some people, they do still prefer to book appointments and going that way, but having that both of those offers is something that has worked well, and that's something that will also be pushed around offering the flu vaccination so that people can just easily access it without necessarily having to book slots and times and places. So they're going to take that forward as well.
Okay, thank you. That's very comprehensive, Claire. I'm conscious that we're ahead of time, and therefore Martin isn't actually available for our next piece, Martin Cooper. So we're going to move on and we'll come back to that. So Claire, you're back in the spotlight again, and I'm going to move on to the Workforce Race Equality Standard report.
Thanks, Claire. So I'll take the Workforce Race Equality Standard and the Workforce Disability Equality Standard reports together and take them as read. For both the RES and WDES, they are mandatory requirements for NHS organisations, and all NHS organisations are required to show annual progress against key indicators, and those key indicators for both are detailed in the reports. The indicators are derived from a number of places, including the staff survey and our workforce metrics around how our colleagues and employees are constituted, both in terms of ethnicity and also in terms of disability. The reports detail some of the progress that we have made, and also identify areas where we've still got work to do. And in each of the reports, we've detailed some of the high level plans and responses based on this year's metrics. Those responses have been discussed with both of the staff networks that support the work that we do, both around ethnicity and disability, and have been endorsed by both of those networks. I think it's fair to say that more broadly within the last 12 to 18 months, we have certainly raised the profile and the focus around our work on equalities and inclusivity, noting, however, that we've still got some work to do. Having appointed an equality and diversity lead in terms of Alison Pearson, and that has made a significant difference in terms of us being able to focus some resources and attention on some of the work that we have to do, and we're hopeful that we can continue that. As well as the work that we've done in Sherwood, as is detailed in some of the reports, we've also worked with colleagues across the Nottinghamshire system to do some of the work together, particularly around the promotional events. And of the actions that are detailed in the reports, I'd just like to point out that they do form part of our wider equality and diversity and inclusion strategy, and that is overseen in terms of progress by the People, Culture and Improvement Committee, and will continue to do so. For assurance, we are required to publish our RES and WDES findings for this year, and they have gone onto our website and did so within the required timeline, which was Tuesday of this week. I'll pause there and happy to take any questions.
Thanks, Claire. And I know some of the feedback that Manjeet has given me indicates that she would welcome this coming back to the People Committee, specifically with some more analysis as to why some of those measures have deteriorated. What we understand to be it's a bit of insight into what the reasons are, and perhaps that would be a good opportunity for the People Committee to discuss that.
Yeah, happy to take that forward. And just to add, Claire, I think that there are two things for us. One is kind of making good progress against the metrics. The key thing that we are also really keen to do is make sure that we move the dial around staff experience and inclusivity across the board. And I think there's some work for us to do that we are discussing through the committee about really setting our own ambition around that as well. So yeah, that's in hand.
Okay, and hopefully then with the People Committee that will also inform how they set that work programme once we've got a bit more of that insight and evidence. We've got a couple of questions, Graham, and then Barbara, and I know Dave, you want to come in as well.
Thanks, Claire, and yeah, thanks very much for what I think is a good report and is clear, and I particularly like the action plans, but what I would like to see is something beyond the action plan a little bit, which is you were saying about our aspirations where we'd like to get. It would be nice to see some targets in some of the key areas, and how those action plans, we can measure then how effective those action plans are moving us towards those targets going forward. I think if we build that into it for the future, it can make a big difference.
Thanks, Graham. Yes, and we will definitely do that. And to add, that's also something that we are talking to colleagues within Sherwood about, but also more broadly across the wider Nottinghamshire system, and learning from other networks as well into other organisations. So that's definitely in hand for us to do.
part of that would also be useful to an element of benchmarking, perhaps, particularly within our system, but then a little bit wider across the Midlands.
Thanks. Yeah, we'll include that, Graham.
Okay, thank you. Barbara.
Thanks, Claire. So just really wanted to pick up on the fact that in the disability report, there's still quite a lot of people employed by us who are not declaring their status. So we haven't got a complete picture of what's going on there. And I just wondered what plans there were to kind of stress how important this is and yeah, seek to improve that picture.
Yeah, thanks, Barbara. And this has been it's a bit of a thorny issue for us because it's been evident over the past couple of years as well, in that we know from other indicators, for example, the staff survey, that there's a greater response from people declaring that they have a disability than is on our system. So we are going to do some work to promote that and utilise where we can other conversations to encourage people to record their information correctly. So, for example, when people are engaging with the Occupational Health Service, when we employ people and take them through an induction process, so to do a variety of things, as well as some broader communication on that. Often people don't always update their information on ESR as regularly as they could do and can do. So that's something for us to work on. But equally, quite often, people with long-term conditions don't always appreciate that actually they are able to record themselves as having a disability. So I think there's also some wider education for us to do on that and to enlist the support of the staff networks to help us with that.
Thanks, Claire. And then just to pick up, really build on comments Graham was making, they're relatively small numbers for some of these issues, you know, questions. So I just wonder whether we need a longer view about trends rather than comparison from one year to the next, just so we can get a general overview of what's happening.
Yeah, I would agree, and also to see how that relates more broadly in terms of other organisations, so to see how we compare. And I also think there's a bit more work for us to do to really get underneath some of the staff survey responses and look at how we analyse some of that information in some slightly different ways, knowing what we've got from both the RES and the WDES scores. And I'm not sure that we've done that overlay in quite as robust a way as we could do. So we'll also take that forward as well and bring that analysis through the subcommittee.
Thank you.
Thank you, Julie. You wanted to come in?
Yeah, thank you. I'm the executive lead for the One network, and I think it's fair to say this is probably our slowest network to get going. We have now got a chair who's a senior nurse, and I think we will begin to get some momentum around this, but I do think the network is the real key here, and it's definitely been the slowest. So we're committed to learning from others to see how they've got this network going as well, because my experience in a previous trust was this was the most difficult network to really get going. So I'm sure we will update progress next time you see this.
Great. Thank you. Okay, Dave.
It was just a minor comment, and I apologise I didn't pick this up before last night, but I just wondered, Claire, if maybe we should have a conversation about some of the medical workforce numbers in there. Just looking on page 2 of the first report, it's saying that we've got 533 BME consultants and 734 white or non-stated consultants. And I recognise I'm quite busy, but I think that makes me bigger than NUH significantly. So there may be something that we need to think about.
I think there's a bit of an error there, Dave, in the report. Well noted. We'll correct that in terms of moving forward. Apologies for that.
Thank you. Okay. I know we still haven't been joined by Martin, so I'm going to move on to item 12, which is the strategic priority to achieve better value, and the ICP report. Over to you, Richard.
Thank you, Chair. Hello, everyone, again. So this is the update on Q1 for the Midnots Integrated Care Partnership, ICP. As detailed in the report, this is about where we're putting our collective effort in, trying to add value over and above a single organisational approach, noting, as we've heard so far through board, and we will do for the rest of the board, that we're living in a world with COVID in our organisations and communities. So the report that we have seen today came to our public ICP board on the 19th of August. I felt that it was well received by colleagues and also the users of our service in the communities. I hope that the format is now familiar to people, so it identifies the 5 ICP objectives and the 10 breakthrough objectives. On reflection, as I always sort of tend to do, it really is just a high level detail of some of the things that we're doing. And we got into quite a detailed, and I felt quite a rich conversation in the board about sort of some of the actions and difference that the ICP collectively is making for people, as detailed in the report. And we have heard in some previous Sherwood board conversations, some of the highlights include progress with funded childcare, and we heard from memory last month about the work that's taking place at Bellamy Road. Whilst we're talking about the Midnots Integrated Care Partnership, the ICP, just some other updates to provide. So I've been the executive lead for the ICP now for probably about 2 years. It's been agreed that Hayley Barsby, who's the chief executive of Mansfield District Council and has been the deputy of the ICP, will become the exec lead for the Midnots ICP. And I know that Paul and colleagues are really keen to continue to work closely with Hayley and to ensure that Sherwood plays a meaningful role in the ICP. Nationally, the term ICP is going to change and is going to be known as place-based partnerships. So PBPs is now the term going forward, will be not ICPs. And as we see the likelihood of statutory change in terms of integrated care systems going through Parliament and be legally enforced from April 2022, PBPs, the place-based partnerships, are going to evolve to have greater accountability, including accountability for some elements of NHS finance, which I think is a good thing. So to ensure that NHS finance is being managed at a PBP level, it's important that they will have a named NHS officer, but that does not stop the executive lead for the PBP coming from the local authority. And across Nottinghamshire, as many of us will know, we've had 3 ICPs, the South, the City and Midnots, and Bassetlaw. There's been a change in sort of geographical footprint, and Bassetlaw is coming in as the 4th. And I know that Cathy McLean, who's the independent chair for the ICS, is keen to look towards greater ways of consistency in terms of working delivery and governance across the 3, soon to be 4 ICPs. So to conclude, as I've said previously, system working does require a huge amount of effort. I think it's made effective by high levels of trust and strong interpersonal relationships, whether they're individual to individual or organisation to organisation. That takes time, but I think we do have those in Midnots. I'll pause there. I think Barbara might have a comment. Yeah.
Barbara, you've got a question.
Thanks very much, Richard, and thanks for the report. What would be really great next time the report comes, so next quarter, I guess, and perhaps once you've moved on, is to really highlight those objectives or areas of work that the Trust has a very specific role in pursuing or contribution to make. The document in front of me is very good at describing the various contributions from the partners at large, but understanding where we can add value as a trust would be particularly helpful, please.
Good point. Yeah, Paul has got a comment that may well be in response to that.
Yes, thank you. It is in response to that. Richard made reference to the conversations that I'm having with Rachel Munton and Hayley Barsby on certainly how I can continue Sherwood's contribution into place-based work, and that is exactly one of the things I'll be discussing with Rachel and Hayley, the contribution that Sherwood can bring and where the place-based partnership and Sherwood's objectives are common and we can work together to achieve.
Okay, thank you. Also a question from Graham.
Thanks very much, and thanks for the update, Richard. I think this is definitely moving in the right direction, and I think increasingly over the next 12 plus months, having a strong focus on place and therefore place-based partnerships, if I've got that right this time, going forward for us is really important. And I totally agree with Barbara that understanding the elements that we can best influence and work on and develop so we can make sure we're doing that will be really helpful. I think also it will be helpful for me as a next step within the development of this is understanding a bit more of where we want to try and get to on each of these areas, and how we actually show the effectiveness of some of the actions we're putting in place and whether they are working or not. Some of them are going to be really difficult to do. I know, I mean, yeah, some areas, particularly I remember smoking in pregnancy. I remember looking at 15, 16 years ago, and it's still an issue and it always will be, but understanding a little bit more what we want to achieve in real terms and where we want to get to and how we measure up on these would be really helpful going forward. Just to, be able, and I think that will give us the opportunity to demonstrate the impact of the changes we're making as well, and that will make it all the more effective.
Can I respond to that? Yeah, perfect. Thank you. Yeah. No, I think helpful comments from Graham and from Barbara, and as Paul said, he's already having conversations with Hayley and with Rachel Munton, the independent chair, to sort of pull some of this together and to see how Sherwood can truly add value. I think there's an interesting conversation for whether it's Sherwood or any other provider to have over the coming months, and we've touched on this before. Healthcare and sort of wider care, health and social care is increasingly becoming quite complicated, and whether it's through the lens of Sherwood or another organisation, I can think of at least sort of four areas that we are working with at the moment. The first bit clearly is we've got our statutory responsibility to provide safe care to patients, and that is our core business. We're talking today about place-based partnerships or integrated care partnerships, and as we've heard previously, and I've always tried to state the case, it does take up quite a lot of time. More recently, over the last 12 months, provider collaboratives have sort of begun to gain some traction, but to build, as I said previously, the levels of sort of trust and interpersonal relationships, you have to put a lot of effort in to get that ball rolling. So provider collaboratives take time, and then we know that integrated care systems are here to stay, and we saw yesterday that the chief exec roles for ICSs have gone out to advert, as have some of the chairs. So there's four meaningful roles, or four meaningful places for Sherwood to work in. Clearly they're not all discrete, they're intertwined, but within that finite resource, whether it's time or people, there's the bit about determining how we apportion our time and effectiveness over the coming years, and it has to be determined, as I think Graham and Barbara was describing very clearly, about where can we get the maximum impact for the people that we serve.
Thanks, Richard. Perhaps just one question then from me. You talked about the role of Bassett Law as the fourth place-based partnership. So how do we think our relationship across that border on behalf of our patients and their patients will work in terms of building the relationships?
So through the lens of Sherwood or Mid-Knots?
Through the lens of Sherwood, but also through the lens of the Mid-Knots partnership, because obviously that's a slightly new element for us.
So through sort of in reverse through the ICP, Rachel and I have previously, in particular Rachel, but I've been involved, as have Hayley. We've made contacts with Bassetlaw. We've got some working relationships with them. I think there is a commonality of interest in what we're trying to do, and I think that will work quite well. There will be, in the way that we've heard, I think earlier today, about the patients who are jointly under the care of NUH and Sherwood. To a lesser extent, there will be patients to the north of Sherwood who are jointly under the care with Doncaster and Bassetlaw. I think that our relationship with DBHFT is not as strong as some of the surrounding organisations, NUH, Notts Healthcare, Chesterfield. But a number of us have worked there previously. I'm sure that Dave and Julie and others have clinical relationships up there, and it's something that we would look to explore. It makes perfect sense to work effectively, whether it's through the lens of employment or care or other factors with the organisations around us. As we've seen in the report, we are stronger when we work together, and I think we will see in DBHFT an organisation that wants to work with us. I would, with all that sort of positivity, I would just counter that with their life will be getting more complicated because they're now being, as the chair is slightly smiling, their life is more complicated because they're now working across at least 2 patches, possibly more, and we know that these boundary changes that have taken place across the country in some areas were not strongly supported.
Okay, thank you very much for that. Okay, we're going to go back now to the report from the Guardian of Safe Working, and I'm really pleased that Martin Cooper has joined us. So Martin, as the Guardian, I'm going to ask you to present the paper that we have already read and had an opportunity to consider. Over to you.
Thanks, Claire, and apologies, I've just dashed back from the TIA clinic, and I see had an invitation to appear early, but unfortunately that couldn't happen. I've only just seen.
That's all right. We've accommodated and moved things around. You're absolutely fine. Patience first.
Thank you, and first of all, thank you to Rebecca Freeman and Jane Cresswell for putting the report together. As you'll have seen, it's essentially in 2 parts. The first describing the sort of data mainly about exception reports, and the second some qualitative description of what this means, and also perhaps where things we might want things to go in the future. So I'll sort of touch mainly on the data first, but sort of with some of those thoughts about those interpretations perhaps as we go along. I think the first thing for me, and as you know, this is my first time presenting here and first report, but for me, I was impressed that there was just one immediate safety concern that was raised, and it was just one, so that was pleasing, and that was raised in the emergency admissions unit on a busy Friday night shift, and essentially came down to the fact that because of exceptional circumstances on that one shift, they were short-staffed. And for me, I'm pleased that you know, the business case that the board will have been familiar with, the business case for increased staffing in medicine, I would feel addresses that and would reassure me that steps have been taken to improve that situation there. The second thing I'd like to highlight was that, again, as you're aware, exception reports are raised by the Tier 1 and Tier 2 doctors, junior doctors, and then need a response from the educational supervisor, sometimes the clinical supervisor. Unfortunately, for the period that we're looking at, a third of the reports have either had a delayed response from the educational supervisor or no response at all. And I think that is something I want to explore further. And I think there's a bit of work to do to raise awareness of the whole exception reporting system with more senior medical staff. Moving on, again, you'll have noticed that 3/4 of the exception reports come from medicine, and the vast majority of these come from juniors working in their base ward environment. So again, as you're probably aware, the juniors and the medical rota, whilst based on their home wards, will be pulled for stretches at a time, 2-3 days, perhaps 2-3 nights, to cover EAU and admissions. But it's really whilst they're working on their base wards that the majority of these exceptions have been raised, and they're really to do with working longer hours rather than missed educational opportunities, although there were or supervision issues, of which there were just 1 or 2. So I think this is no surprise. I think we've all recognised that working in medicine has had its own particular stresses and strains in terms of impact on doctors. And again, the board will be familiar with this, having seen and approved the business case for medicine to increase staffing at junior level. It's mainly on the wards, but also to support some of the out of hours work done as well, and we'll touch upon that again shortly. So no surprise that 3/4 of the exception reports are from medicine. I think also for me, no surprise that half of the reports come from F1s, even though the Foundation 1 doctors, even though they make up only about 1/5 of the workforce, they are producing half of the exception reports. And I think there's probably a number of reasons for this. Partly, I think the F1s, we put a lot of effort into sort of making the F1s familiar with the whole exception reporting process, encouraging them to report, and sort of course, have a captive audience with them when they first arrive in the trust. So I think they're probably more attuned to this. But I think also it's a reflection of they probably bear the brunt of the work, that ward-based work that I've described earlier. And I see, we see spikes in these reporting, and the next report that I'll bring to board will be covering the August changeover. So we see spikes at changeover, but also I think we can see spikes occurring at if I call it winter, that's in inverted commas, because it feels a bit wintry at the moment, and not just climate, but in terms of workload. So I think no surprise that it's the F1s, and that we see these spikes occurring at times of new induction, when they're perhaps finding their feet a little bit, finding their feet in terms of their working practices, but also when the workload is particularly high. Just moving on then, and again, I've touched on some of the changes that you'll be familiar with to the working makeup from the increase in junior doctor numbers. And of course, one of the things that preempted that was moving the Foundation 1 doctors and the clinical fellows onto the out of hours rota to cover weekends and nights, to increase numbers there. And I have to say that's been generally well received. I think the impact of that in exception reporting will be yet to be seen to work through. But I've taken the opportunity to sort of wander around the wards a little bit, take the opportunity to speak to juniors on the ground, and certainly that has been well received. They feel better supported now in their out of hours work. And I have to say, as a consultant working weekends, I feel better supported by juniors at weekends because there's more of them. So that's most welcome. But of course, pulling them to work out of hours and weekends detracts from having them on the numbers on their base wards. But again, I think this is where the the business case has helped out. So the plan, the aim is to have wherever possible the increase in numbers to make a minimum of 3 tier 1 doctors on each base ward at any one time, and I think we'll have to monitor that closely and see how that is going forward, because these changes have just come into place. But I'd certainly hope that will then have an impact on the working hours and working lives of our most junior doctors, and that'll be interesting to see that work through, particularly in the next report. And of course, that business case, the other change that it made was to bring senior clinical fellows and some other tier 2 doctors, so IMT 3 doctors, to boost a shadow medical registrar rota. And again, too early to see any of that feed through, but again, anecdotally talking to colleagues, that's been very well received. And I think the role of a medical registrar, particularly out of hours, has been a very onerous one and a daunting one. And I think it's good to see that that might well, that's going to change. And I think having that shadow rota, I think, reflects more of what we see. You were talking just before I joined about relationships with sort of neighbouring trusts, and we know that neighbouring trusts do tend to have a greater presence than we have had historically for our tier 2 doctors at night. And so I think that's certainly going to make an improvement. And I think we're going to see a knock-on effect there, in that we've sometimes struggled to staff some of our our sessions that have come up, vacancies at short notice due to sickness or whatever at short notice, and I think there's been a reluctance for trainees around the region, tier 2 trainees, to come and fill those shifts because they have been onerous when compared with, say, Nottingham or Derby. Whereas I think now we're going to be in a much better position to be able to fill those posts, and I think make sure we're a more attractive place to be, not just temporarily, but hopefully long term. Priorities for me then, I think, now and moving forward, I think you will have seen that, as I mentioned, the majority of, or half of the reports come from F1 doctors, but no reports in this period coming from T2 doctors, tier 2 doctors. And of course that, there are some very good reasons for that, but which will include the fact that they're more familiar with their working practices and so on, their time management is better. But I would be concerned that I would hate to think that we're missing out on some of the reality there. So I think I'd be encouraging tier 2 doctors to be perhaps more engaged with the process than they are at the moment. And as I said earlier, I think that goes for consultants as well. I think we need to have a greater involvement with consultants in the whole process, and both myself and Rebecca Freeman, as head of the medical workforce, will be planning to attend and deliver sessions at the Educational Supervisors Forum to address this and raise the awareness of getting timely reporting and timely response to reporting more of the norm rather than the exception. As I've said, I've tried to make myself a bit more visible about the wards, and this is something I want to continue with. I think exception reports tell some of the story about what's going on with our medical workforce and can reassure us to some extent. But I think actually hearing the lived experience from the juniors on the ward, I think for me is a vital part of that, to bolster our understanding. So I'm keen to continue with that. I met regularly and will continue to do so with Chief Registrar, and I'm, as I say, keen to have to continue to meet juniors on the wards and to see what their lived experience is. With a view to what's just around the corner, if not upon us already, winter and COVID recovery. And both of these, I think, are going to put an extra strain, as we know, on all of the workings of the trust, and we'll see that in the workings of our junior doctors. And I think it will be very interesting to see the effects of the changes we've made in terms of workforce that I've already spoken to. But I think there are still some vulnerable areas that we need to monitor carefully. As you know, winter is a time when we increase unplanned admissions, and planned admissions and elective work takes a bit of a knock-on. And I suppose where I see that is medical outliers going into surgical beds. And I think we have to make sure that we have robust systems to be able to make sure that those patients are well looked after from a medical viewpoint. And so that's something I'm very keen to focus on in the forthcoming period. Most of the exception reports, as you'll see, and I've said, have been due down to hours, but I'm conscious that you know, the HEAM has talked about a COVID training recovery plan, because a lot of educational opportunities have been missed by our junior doctors. And I think part of my priority will be to work with our Director of Medical Education and to make sure that those educational opportunities, and especially catch-up educational opportunities, are still being able to be taken by juniors, even when they're having to face an increased workload with the clinical COVID recovery and the winter pressures. I haven't mentioned clinical fellows because, of course, the whole exception reporting is about the junior doctor contract, which doesn't cover clinical fellows. But I think I'd be keen to try and include the clinical fellows in the exception reporting process. We've done some great work here in Sherwood to enhance the experience of our clinical fellows. We have them in formal educational training programs now. They have educational supervisors, they have portfolios just as the doctors in training do. And I think that has a very positive knock-on effect in how Sherwood is viewed, not just regionally, but around the world. I mean, it might sound strange to say, but word gets back. We have a lot of international recruits, and they tell their fellows elsewhere, their colleagues elsewhere, just about their experience. And I think I feel pleased at the moment that experience is a good one. I think we're in sort of bringing the clinical fellows into the fold of the exception reporting scheme. I think will show them that we're taking their working lives very seriously. Just one last thing that I'd be keen to do is to try and sort of forge links myself with guardians of safe working in neighbouring trusts and around the region. I think there's a lot to be gained by looking at experiences elsewhere and not reinventing wheels. And so I'm keen to sort of forge those links and take from that whatever I can. So that's all I have to say. Happy to answer any questions.
Thank you very much, Martin, and I think they're very comprehensive. I did have one or two questions, but I think you may have actually answered those. I mean, essentially around how we tackle some of the issues in not just encouraging more reporting from the F1s, but then looking in a bit more detail of what sits underneath that. So because obviously we want to encourage as much reporting as possible, but equally we need to be able to understand in the analysis what's going on there, and I think you've covered that. And I know that Barbara has just put a point up to say that she would welcome the inclusion of clinical fellows in that scheme. They are a great resource to this hospital, so it'd be really good to understand what we can do there. So thanks for an excellent report. I'm not sure that we've got any questions other than in the chat there's endorsement of this report and your presentation. So thank you, Martin.
My pleasure.
We look forward to seeing your next report and analysis as you understand and get into the role a little more as well.
Thank you very much.
Okay. Thank you.
Bye-bye now.
Thanks, Martin.
Bye. Okay, we now go to our staff story, and I think we've been joined by Becky and Debbie, I hope. Perfect, I can see them online.
Hi Claire, it's Claire. Yes,
Hi, Claire.
They're here. Yeah, they're here. So we'd actually normally be joined in any event by Becky at this time of the year, because we've just done the flu report, and she does tend to join us at the board for part of the delivery of that. But we're joined today by Becky Loveridge, the Head of Occupational Health, and Debbie Kersley, Head of Operational HR, to talk us through some of the staff story in terms of the Occupational Health Service during the pandemic. And we'll have seen each time from the Strategic Oversight Framework reporting just how busy that service has been throughout the pandemic, maintaining the delivery of both the core offer and providing additional support to colleagues and their wider families. So I will hand over to both and to say thank you for taking the time to join us.
Thank you. So hello everybody, good morning. Thank you for giving us the opportunity to, I'm always very keen to promote the Occupational Health Service, as those of you who know me will be fully aware. So if we could have the presentation up, please. Thank you. Could it be made any bigger, or is that as big as it goes?
So that's as big as it goes, Becky, sorry.
That's as big as it goes, okay. Fine, thank you. So I'm going to give you a brief overview of the occupational health story during the COVID pandemic. If we could have the next slide, please. Just to give a bit of background, the Occupational Health Service that we have at the Trust is a nurse-led in-house service made up of a multidisciplinary team. We have sessional consultant occupational health physicians. We don't employ them directly, we buy them in on a contractual agreement with Nottingham University Hospital's Occupational Health Department. But our lead physician is a gentleman called Dr. Murphy, and he's worked with us now for over 5 years. We have specialist occupational health nurses, registered general nurses, occupational physiotherapists, and our admin team. And our department is based on the ground floor of TB3 at Kings Mill, and we hold a weekly satellite clinic every Monday at Eastwood Centre at Newark Hospital. Next slide, please. So before the pandemic, utilisation of our service had already been substantially increasing, and we'd seen a 46% increase in activity over the last 5 years, and that was before COVID. So demand for core occupational health services had been on the up for the last 5 years. Next slide, please. So what was the impact of COVID? Well, to be frank, it was massive. We experienced significant pressure on the service from the very start of the pandemic, and that continues today. We saw a huge increase in levels of occupational health client interventions, and like many others, we were required to respond to a novel changing viral threat, and our aim was to protect every member of staff and respond to the personal impact it had on them. National guidance was just received so frequently, and it required interpretation, translation, adaptation and implementation, and it really was received at pace and changed so quickly. We had to hold daily briefings for the occupational health team at 8:30 every morning, because it was so important that the team was up to date with the latest guidance. All of my team, apart from 2 members, are part-time, so they'd be off for a couple of days. On their days off, they'd come back and the world was a very different place. So it was really important that everybody was up to speed. The Trust staff really trust occupational health. They have huge confidence in us. So I needed to make sure my team were giving accurate information that was up to date. At its peak, we had quadruple pre-pandemic levels of activity within our service. Next slide, please. And this is demonstrated on this graph. This shows the average number of occupational health interventions, not the average, the actual number of occupational health interventions on a monthly basis from March 2019 to March 2021. And as you can see, before the pandemic, we were fairly stable. We always have a dip in December traditionally, but as you can see, our target of 1,000 was around about more or less reached. And then the pandemic hit, and as you can see, activity levels just skyrocketed. Just to put that into context, that goes into March 2021. Where we are now is over the 2,000 level again. So we are seeing activity increase again. Next slide, please. Next slide, please. Thank you. So how did we respond? One of the biggest things that has been so essential, an element of the response to COVID, has been the provision of our daily dedicated telephone helpline manned by occupational health nurses. And this is for both staff and managers in relation to COVID-related queries and anxieties. The type of calls that we've had has really changed as the pandemic has progressed, and it really has reflected what's happening and the guidance that's out there and what is happening in society. And we've started to, like many others, dread the Boris briefings, because we knew the next day our phone lines would be mad and ringing off the hook. The number of calls we received peaked at 138. That was the most we had in one day. But yesterday we had 79. So as you can appreciate, that helpline is still really busy. And I have 1 or 2 nurses working on it every day. And now we also get a lot of email queries as well as the phone calls. And that has been such, like I say, an essential element, and I can't see that going away anytime soon. Joint working with infection control has been throughout the pandemic, and it's been essential. And we've really strengthened our working relationships as a result. And we're almost seen as one service at time, especially during the peak of the pandemic. We've worked with them to provide a very effective and timely service for staff and household contacts who are displaying COVID symptoms to access PCR swabbing. And that has got really slick as the pandemic has progressed. And we're now able to usually get results if someone's swabbed in the morning later on that day, which is really, really helpful in getting people back to work as soon as possible. We also worked with infection control to lead a trust-wide staff COVID-19 antibody serology testing rollout, and that was part of a national mandate that we were required to do. And we coordinated this with infection control to have a measured rollout to all trust staff. We completed it in 5 weeks over June and July. And we had 82% uptake, so 82% of our staff took up on this offer. Communicating of the results required a real military-style organisation, and we developed through occupational health a very slick, efficient electronic system, which really helped get those results out to people very timely. People wanted this. We had people asking for this. And that's why we had to do it in a measured, rolled out way, because we were offering this to over 5,000 staff. Next slide, please. So, flu, we can't let flu be forgotten. What can I say? It's always a subject close to my heart. We had to arrange the campaign a little slightly differently last year because of the COVID requirements. And I must admit, I really thought we might have problems achieving our excellent uptake, but we didn't. We achieved our highest uptake ever at 87.4% of frontline staff, which was the highest since the flu programme began. We had to we still wanted to offer what we know works. So our grab a jab clinics are so popular. Most of our flu vaccines in this trust are given opportunistically, where people don't have to book appointments. And we know that most of the clinicians prefer that. So we wanted to continue that. So with infection control advice, we moved where we held those. We couldn't hold them where we would normally hold them in the street because it was far too public facing, and we had to move away into non-public areas. But we also provided grab a jab clinics on the floors of the towers, outside wards, so staff really had ample opportunity and really easy access to getting the vaccines. I'm not going to go on too much about flu because I know you've already heard about it, but without the help of our peer vaccinators, we wouldn't be in the good position that we are, and they do an excellent job for us, helping vaccinate as many staff as possible. And one thing I would like to mention about the flu programme last year, for the first time we offered a new initiative, whereas if staff didn't want to redeem their very popular meal deal voucher, which they get a voucher to get a free sandwich, snack and drink when they get a flu vaccine, they could donate it instead to the Street Health Project, the value. And that was really, really popular with staff and resulted in 6.3k being donated to the Street Health Project at the end of the flu season. So that is something we'll be repeating again this year. We also provided some additional targeted clinical psychology support for staff working in particularly hard-hit areas due to COVID, and that was ED, intensive care and the respiratory wards, and that's been a real success story. It's been so welcomed by both staff and managers in those areas, and it's still ongoing, and we're looking at the possibility of making this a permanent offer going forward and extending it to more than those areas. Like many others, we had to look at different ways of working in occupational health and make use of technology and utilise technology. So we have moved to predominantly telephone consultations where clinically we can. We still can't, unfortunately, give a vaccine or take blood remotely. It'd be nice if we could. And that's all our OH clinicians are undertaking that, using technology and remote working to support. And we also wanted to continue with our staff MSK physiotherapy service throughout the pandemic, because we know how important this service is in helping reduce and prevent sickness absence and maintaining staff at work and maintaining their health. So our occupational health physiotherapists provided virtual and telephone consultations. They produced podcasts, they produced screensavers on physical health and ergonomics. So it did continue throughout the pandemic and has proved very, very helpful, like I say, in helping reduce sickness absence due to MSK reasons. Next slide, please. We also saw a real influx in the amount of manager referrals that we received during the pandemic, a 50% increase. There was no way we could accommodate this in our normal manager referral clinic time. So we undertook extra clinics doing COVID-specific manager referrals, and our occupational health consultant, Dr. Murphy, was really helpful in this. He worked remotely and worked in his own time, his extra hours, doing extra clinics, so we could accommodate these referrals, because people needed this advice quickly. They didn't want to have to wait 2 weeks for an appointment. So that was very, very helpful. And we've also had to undertake additional work health assessments. And that is because Sherwood Forest is the lead employer for the vaccination hubs. So all the staff that are recruited to work on the mass staff on the COVID vaccination programme required health screening, health assessments and appropriate vaccinations providing. So that all came through our department. I'm really proud to say that despite the huge challenges and increase in activity to the service because of COVID related issues, we maintained our core services, core occupational health services throughout the pandemic. And there's not many occupational health departments that did that. Most suspended services, other services, we didn't. Next slide, please. Again, something I'm really proud of is that throughout the pandemic, despite the massive service pressures, quality has been maintained and has remained consistently high. We monitor quality both quantitatively and qualitatively. Quantitatively, we partake in a national audit, which is called a Mohawk, and it's a national web-based benchmarking tool, occupational health tool, and it measures evidence-based clinical occupational health practice, which allows us to benchmark with our peers nationally. And when we last did this, our service benchmarks very well against our peers. But more importantly, I think we provide qualitative evidence of the quality of the service, and we do this through an annual anonymous occupational health client and referring manager satisfaction survey. We last did this in July. We do it annually, so I say we did it in June in 2020 and we did it in July 2021. And I think the results of this provide very clear evidence that both trust staff and managers rate the service really, really highly, because 100% of staff who completed the survey considered that overall the care they'd received in the occupational health department was either excellent or very good. I don't think you can get better than that. 100% of staff had confidence and trust in the occupational health professional that they dealt with. 100% of staff considered they were treated with dignity and respect. And 100% of managers considered that the occupational health reports were very helpful in the management of their staff member. Next slide, please. This is a poster. I get a poster done every year after I've done these satisfaction surveys to surmise the results, and I'm sorry it's so small, but this is up in our waiting area now, in our reception area, and it just surmises the results of the satisfaction survey that was done in July. There's a bit of there's an area where staff can make free text as well as answering the standard questions, and I think that the comments that were made by staff who've used our service are really powerful, and I'd just like to read those through in case you can't see them. So, professional and efficient throughout, keep up the good work. Very efficient service, lovely team, thank you. Excellent from point of entry, even I can't read that. At reception, up to leaving, friendly, attentive staff, great job, thanks. Very welcoming and friendly, professional environment. Staff were all lovely, very nice department. A nurse was amazing. I couldn't have asked for a better experience. A much better OH department than others I've been to. Everyone was friendly and easy to talk to. They made me feel so comfortable, and the procedure was so easy, coming from a very nervous patient. So very powerful, positive comments that were made by staff, trust staff who've used our service. So what do those results show? Next slide, please. In my opinion, these results not only demonstrate the exceptional professional knowledge and credibility that this OH service have, they also reflect that occupational health staff clearly work in a way that truly reflects the values and behaviours of the trust, even when coping with the huge additional workload of a global pandemic. I really hope this story has provided you with assurance that the Occupational Health Department provides the trust with high quality trusted services that without doubt support the health of staff. And as such, the service is an integral element in facilitating the restoration of services and enabling trust staff to recover from the pandemic. Next slide, please. So to finish, I'm going to hand over to Debbie, because she's going to tell you about what some of the occupational health team have had to say about their experience of working in occupational health throughout the pandemic. Thank you, Debbie.
Thanks, Becky, and good morning, everybody. Next slide, please. Thank you. So the next two slides have some reflections from members of the occupational health team about their experiences over the last 18 months. And I won't read through these, you can read these at your own convenience. But I believe that these reflections are really powerful and evidence the challenges that the team have faced with significant increase in the demand for advice, guidance and new services that Becky has articulated, while also providing business as usual activities. However, the reflections of the team members also that demonstrates that the team does have exceptional teamwork and ethos where they support each other through those really difficult times, but also through those better days. And this has resulted in the outstanding services that have been delivered during the pandemic, as evidenced by Becky, and those excellent results from the surveys. But what is also clear from the reflections is that the occupational health team have rightfully been recognised as a vital key stakeholder within the organisation, and the profile of occupational health has increased within the organisation. And those relationships with managers, staff and other departments such as infection prevention control, HR and other departments have flourished during this time. So while the pandemic has posed some real serious and significant challenges for the service, it has also presented some opportunities which staff have valued, enjoyed, and hence there are some real positives. The success of the Occupational Health Department in general and during the pandemic has been down to the team members and their excellent teamwork, but it's also the exceptional leadership skills and qualities of Becky, who has demonstrated significant experience, knowledge, compassion and authenticity, along with being responsive and flexible to the challenges. So personally, I'd like to say thank you to Becky and the team. Thank you. That's the end of our presentation, and Becky and I are willing to take any questions.
Thank you very much, and what a great example of a service that has also provided support to staff, not just within your service, but much wider across the rest of the trust at what we know has been a very, very difficult time. So thank you very much for that. And there are lots of comments from our non-executive directors and board in support of the work that you're doing. I know Richard would like to come in as well on a comment. Richard?
Thanks, Chair. Thank you, Debbie and Becky, for a wonderful presentation. More importantly, thank you for the work that you both and your teams have done over what has been, as we've described, an eventful 18 months. Just want to take the opportunity, Becky, to thank you personally. You and I caught up a couple of weeks ago. I'm not sure everyone's aware, but you're stepping down in January, is it? I think January as the head of Occupational Health Services, and you've been absolutely fantastic. You've been the person that has led the service with real intent and compassion for many years now, and as many of us have either used your service or know people who have, and it's always been first class. So thank you, and I'm delighted that you're returning to a couple of days a week after your retirement as well.
Thank you, Richard.
I think we had a freeze of communications there for a moment. I've got obviously some comments that have come in here from lots of the executive teams thanking you for the work that you're doing. Andy Haynes is asking, what else can we do to support you? What more can we do?
I think the support that we get is very good. I've told Richard this. I think that the HR function supports us very well. I've always felt very personally supported throughout the pandemic by my managers and by the wider function. And I think that we support each other very well within the team. We are a very cohesive team, a very stable team. And without that, I couldn't have done my job without the support of my colleagues. So I feel that we get a lot of support from the organisation. I feel that the organisation really values occupational health. I feel that they know the worth of occupational health, which isn't the case in all trusts. That hasn't happened overnight, and it doesn't happen without a lot of hard work. But I feel that we're a credible service and that we've got a lot to offer, and a lot to offer going forward. So in answer to your question, Andy, I think carry on doing what's happening now is what I would say. I think the profile of occupational health is really high. I would like to see it higher. I'd like to be seen as a clinical service more than because we are a clinical service, a clinical specialty. So, you know, I think occupational health in the years to come will flourish, because one thing the pandemic has done is the positive of the pandemic is the profile of occupational health and what we do, and the value of what we do, and the essentialness of what we do has really been highlighted. Because a lot of what we do does go under the radar by the very nature of the work. But the pandemic has highlighted how important occupational health services are.
Thank you for that. Thank you very much, Debbie and Becky, for that. Okay, we've come to what I think is a good opportunity for a comfort break for everybody. We're running a little bit ahead of time, so can I ask you to be back for 11 o'clock, and we'll be going straight into the SOF then. Thank you. Okay, I think everybody's back and we can resume the public board meeting now. Thank you very much. Perhaps we can move straight on then, Richard, to the single oversight framework, and I'll ask you to lead this with the executive team.
Thanks, Chair. So yes, this is the single oversight framework, the SOF for month 4, which is July. And as always, we will start with People, HR and OD. So I'm going to hand over to Claire, who's our Director of People, and Emma, who's our Director of Culture and Improvement.
Thank you, Chair. Thank you, Richard. So I'd just like to cover 3 to 4 points that is currently within the People and Culture report this month for July. Wanted to highlight the fact that in July, which is classed as Q2, we had a quarterly staff survey where it's a temperature check in the organisation with regard to how colleagues are feeling and their experiences of working in Sherwood and caring for patients. Analysis of that feedback from colleagues remains very positive in a number of areas relating to the organisation being a great place to work, maintaining the increased satisfaction that we had in our national staff survey last year. Similarly, in terms of the care that's provided for patients, and that colleagues would recommend families and friends to come to Sherwood Forest Hospital. And then also with regards how we take care of colleagues from a health and wellbeing perspective. And I think the presentation earlier from Becky and Debbie highlighting the support of our occupational health service, I think is a good further demonstration of that. And I think the further thing to say is that colleagues in the organisation have expressed that they feel that Sherwood does place patients as our top priority. And that again, I think is just recognition with regards how we care for colleagues and patients. However, there are some areas that we do need to improve on. We're very mindful of those and we're actively taking those forward with all divisions and particularly through our diversity and inclusion networks as well, across ethnic minorities, LGBT+, and our disabilities network. So we will continue to learn and improve. And there's just some headlines with regards to the quarterly survey. What's been key has been quite a lot of pressure and demand on colleagues at the moment. Fully recognise that, but based on listening to colleagues, feedback around how to keep motivated, connected with each other, we put on a Fitness for All challenge throughout July, where we encouraged any member of Sherwood Forest Hospitals to take part in some form of physical action activity, and I'm pleased to say that that was received really well, and the statistics are in there with regards to some of the figures, and we will look to learn from that and continue to build to help our colleagues keep motivated and physically and mentally healthy. We are also, although this is based on July feedback, next month we will have our civility learning and sharing event. So a lot of planning has been taking place the last 2 to 3 months for that event, and Sherwood Forest is hosting that on behalf of our ICS, where we have some national and influential leaders supporting the session, but importantly hearing from our own colleagues with regards to the importance of civility, which our care values totally underpins. And the final thing I'd like to recognise is we shared earlier our half-year priorities, so that's from October to March 2022. A key part of that will be how we continue to support colleagues from a health and wellbeing perspective. And Claire Teeney, Director of People, and myself, working with the operational teams and other leaders, will be looking to put in a programme of health and wellbeing for H2 to support our colleagues through what may be a challenging winter ahead. So I will pause there and take any immediate questions or hand over to Claire. Thank you.
Thank you, Emma. No immediate questions, but perhaps we'll take Claire and then we'll see what we've got in this section.
Okay, thank you both. And the key thing for me to draw out is just around workforce capacity, really, as Emma and other colleagues have alluded to throughout the board meeting. So overall, non-COVID sickness absence is higher than we have previously experienced, and then that's compounded by both COVID absence and also isolation for colleagues as well, which has had an impact at a time as well when we have seen increased amounts of annual leave, which is much needed, but it further does impact on overall capacity, and Simon alluded to that in the first part of the board meeting. As we've heard throughout, we are doing a significant amount to support health and wellbeing, both COVID related and non, for colleagues, and have run a strong programme throughout the last 12 to 18 months. And as Emma said, we will be further developing that to provide additional support where we think it's needed. Becky Loveridge in the occupational health update did refer to the psychological support that's been put into the clinical areas. That is something that's been well received, and we will be continuing with that throughout the winter months. In addition to that, we do have access to specialist psychological support through the Nottinghamshire Health and Wellbeing Hub, which has been set up for health and care staff to be able to access across Nottinghamshire, and we'll be making sure that that has improved and increased visibility. We have already had staff referrals through to that that has helped return colleagues to work sooner than they would have otherwise done so, and also prevented them from going off. The final thing that I will say about the Onward Health and Wellbeing offer, we will be building in some more robust evaluation so that we can be clear that colleagues that do need the services are the ones that are accessing it, and that will help inform what we do around future health and wellbeing and provision. We've got some analysis in place, but I think it's an opportunity to do that with a bit more rigour. I'll pause there, thanks.
Thanks, Claire. I've got a question from Neil.
Yeah, thanks, Claire. Just a question about the sickness and absence. I note that it's gone up from 4.9% to 6.3% in July 21, and that equates to about a 29% increase in the number of people off sick. I just wondered what that means in terms of the number of people and what the cost implications are of having to backfill that with bank agency or locum staff.
I haven't got all of those figures to hand, Neil, but I can bring that through and we can do some further work on that at the People Committee. We have seen an increase, though, in agency usage, so we do know that those costs overall will have increased, and I think that the forward look, unfortunately, around that is that that's probably going to continue into the next few months, which is why we're doing what we can to prevent some of those absence issues where we can. But I can get those figures and forward that information on to you.
Okay, thanks. I mean, I suspect it's an annualised figure of in excess of £1 million, I suspect, but it'd be good to have those figures to understand what they are.
I can do that, and I would suggest that we keep an eye on the detail of all of this through the committee, because I think it's going to be an important area of focus for us, certainly over the winter. I am concerned about the longevity of the health impacts that the pandemic has had on colleagues, and limited time, if any, for people to be able to recover, and what has been ongoing asks, and with a forward look that is going to be one that is going to be pretty demanding, I think. So I think that we do need to ensure that we focus on it.
Sure. Okay, thanks.
Thank you. Andy.
Thanks, Claire. I'm very aware that last winter we provided quite a lot of support to the system, Claire, through the system bank. And there's noises from some other systems about a shift from care homes into the NHS for some workers. I just wondered if we've seen any of that and how you feel we're looking in terms of that care home worker deficit for the coming winter, which I think is going to be tricky.
Yeah, it is. You're absolutely right, Andy, and the whole workforce capacity thing isn't something that's isolated to one organisation, so therefore other organisations can step in and help share the load. It's something that is having an impact across the board. We did provide some limited support into care homes last year, and we will be doing some of that through the bank this year. But what we are doing is ensuring that we prioritise our own hospital services. I think that that's really important, and we have made it clear that we do, of course, want to be good system partners and support where we can. Equally, we've got to make sure that that isn't to the detriment of our own services, which is something that we're absolutely mindful of. But it's not going to be easy. It's not going to be easy for any of us.
Thank you. I don't know. We don't have any more questions for this section, so.
Okay. Thank you, everyone. Thanks, Emma. Thanks, Claire. We'll now go on to Julie, our Chief Nurse, and Dave, our Medical Director, to talk about quality, safety, patient experience.
Thank you. So I'm going to kick off and then Dave will finish. So C. diff is flagging again this month, and we are seeing most significantly an increase in the community onset hospital associated infections. The hospital onset, hospital acquired are stable, but they're not reducing. When we look at the ribotyping, there is no evidence of transmission, so the strains identified are not the same in the clinical areas where we've got multiple cases. We have identified some issues with antimicrobial stewardship and timely sampling, and so we've got the infection control team and the microbiology team going in to do specific teaching with the medical managers, ward leaders, matrons, etc. We have also had an interruption to our UV and HPV cleaning that was at the beginning of August, and the numbers in August have gone up again. So that's just forward notice of that. We have got a detailed paper going to Quality Committee on the 13th that looks at the demographics of these patients. We've also pulled together a system meeting around this because of the sharp increase in the community onset, although we can't sit on our laurels with the hospital acquired either. And we've got some help coming in from the regional team. From a cleaning perspective, the deep clean is recommencing, and we have now got 3 HPV machines on site plus UV. So I feel confident that cleaning is resolved, and we're getting a weekly report from MediRest colleagues on that. For the emergency department friends and family tests, we continue to grapple with the response rates. They are now piloting the QR codes from September that we've got in maternity, and a deep dive of that came to Nursing and Midwifery and AHP committee, and will go through to Quality Committee on the 13th again. What that deep dive does show is that our score is significantly better than the national average, and perhaps our ambition of 94% is not a realistic target. So the Quality Committee are being asked to consider whether we should reduce that target, because it looks as though nationally the performance is around 78%. We'll be able to feed back on the Quality Committee's views on that. From a complaints perspective, complaints are increasing, although they're not at the pre-COVID levels. We have got the vaccination hub reporting into our complaints procedures. So although they're only 19, they are complaints that haven't been previously in our complaints. The top 3 themes remain unchanged around clinical care, clinical diagnosis, and then communication issues with admission, transfer and discharge. The medicine division have the largest proportion of these just because of the high volume of patients that they care for, and they have agreed to do a pilot of the clinical team contacting the complainant at the first point of contact. When you read these complaints, I think a lot of them could be resolved informally at the point of receipt. So the team are planning to try that. So although it does on the face of it look like they are increasing, and they're not back to where they were pre-pandemic. Over to you, Dave.
I was going to bring up a couple of points, pick up the VTE, which is just a smidge under the target, and you'll all be aware of the long history of this, and the solution that we've been talking about for some considerable time around the electronic capturing of this. So I'm pleased to be able to inform board that I've seen the screenshots for the electronic system and the process and been through that. I've taken that through the clinical chairs who've made a number of comments, and that's been cascaded through the clinical teams. And that will then be approved and go through to be built into our EPMA, our electronic prescribing program. It wasn't launched in time for the pilot, but it will be coming into the full program when that goes live. So I think that's real progress there. And then in terms of the other indicator I wanted to just touch on was around cardiac arrest calls. So we've seen 6 cardiac arrest calls in July, and that's what's caused a slight uptick. We have talked about this before, and talked about the learning is the key bit for cardiac arrest calls, and to understand exactly what the 222 or the calls are being used for. And the uptick is it describes in the papers that 2 of these were do not resuscitate patients who were then a call was put out. In fact, one of those patients was a patient who choked on some food, and so probably putting out a call was entirely reasonable, and that patient didn't arrest, but there was a significant call for help. We've tasked the service to review the learning and to update on that. I think that comes in the latter part of this month, and then to benchmark us more regionally, and that comes in next month. So I'll bring those updates as they're available. Happy to take questions for Julie or I.
Thank you. Perhaps while colleagues are thinking about it, I've got a couple of questions. First of all, Julie, on the antimicrobial resistance issue, what do we think was the cause of the spike or the issue there? I noticed that we say that we are reassigning pharmacists to antimicrobial duties. Is that because they've been pulled away as a result of the COVID vaccination service or other issues?
Yeah, that's correct. So quite a lot of pharmacists were redeployed, so they have been now reinstated in their roles and are beginning the audit programme again. We've also got the regional antimicrobial pharmacists doing some work looking at our community antimicrobial usage. When we've looked at the patients that have acquired C. diff or have associated C. diff, 73% of them had 2 or more doses of antibiotics, and 72% of them had had an admission in the prior 4 weeks as well. So I think these are complex patients, and the lead microbiologist and that regional pharmacist are going to have a really good look at it for us. What they did say that on the face of it, our antimicrobial usage within Nottinghamshire is actually one of the lowest in the countries, but Lincoln's is fairly high. So we're just looking at the postcodes of these patients as well to see if we can understand this a bit further. But as I say, Quality Committee will get a bit more detail on the 13th, and then we'll bring a fuller update when we've got the regional input in November.
And you mentioned also that we have purchased some additional UV HPV machines. Are we satisfied that we've got sufficient for all those areas? Is there anything else that we should be looking at in terms of providing additional resource? And are those not just here, but across the whole of our estate, including Newark?
So they are across all 3 hospitals. We had a terminal failure with one of the HPV machines that meant that all of them had to be decommissioned because of a manufacturing risk, and that's what caused us to be reliant on a small number of UV machines. So we have now got the new ones on site. Everybody's been trained in them, and they are out and in use. So yeah, I'm comfortable with that, and we've got a good reporting system from the Estates and Facilities team now as well, and they're also monitoring the infection rates on their dashboard, which triangulates it with staffing numbers and cleans, etc. So we'll get a different viewpoint on this from the work they're doing as well. Okay.
And just another question on one of the other areas that you covered, Julie, in relation to the complaints that we've seen. So where we've got complaints on clinical care and treatment, Are they focused on particular divisions, or are they focused on particular specialities? Is there any additional data you can provide us with?
So medicine get the most complaints, but if you look at it per 1,000 bed days, actually they perform quite well. I'd say surgery is a bit of an outlier, and we've asked for surgery to bring some more detail around their learning from complaints. And women's and children's is another one that is a bit of an outlier. So they are doing a piece of work through the Nursing, Midwifery and AHP committee, and we can share that through the quality committee when we've got further detail. We thought that getting medicine to start with the clinical contacts will give us kind of the largest pilot area to begin with.
Okay, thank you. Dave, did you want to come back in?
Yeah, I was just going to make a comment on the first point you made around the antimicrobial stewardship. I think for me, this is something that's everyone's business, and it's relatively easy to say it's all related to pharmacy, but actually there's a huge component here that we need to task the clinical teams with. Not only that, it's usually led by our microbiology, one of our microbiology consultants, and I think it's fair to say that our microbiology service, along with our IP service, has been significantly stretched in the past a little while, and giving them some headspace and the ability to sort of reinvigorate antimicrobial stewardship. Tasking our divisions to complete the audits and to actually utilise the audits, and all of those aspects I think is really important component of this, and Julie and I work together to take this forward, and the key bit is around education. It's education really with this, and you know, we have the review dates on the charts to try and stimulate that. That will go on to the electronic prescribing system to do, but you know, this is a constant task to actually just say, do you continue to need these antibiotics? Can we stop them, or can we de-escalate?
Excellent, thank you very much. Okay, Richard.
Thank you. So over to Simon Barton now, who's our Chief Operating Officer, who's going to talk about timeliness of care, which we know is a key contributor to overall safety, quality and patient experience. Over to you, Simon. Thanks,
Richard. Just a few sort of points in general. So as we've reported, the hospitals are under a lot of pressure, both from high demand and complexity, and particularly being felt in emergency care and cancer. We've put on quite a bit of additional capacity where we've been able to do this over the past few months. But as we've reported, it's been a real challenge, both in terms of workforce being able to get the rest that they need, but also the supply in terms of absence due to isolation and the like. So that's been challenging, but we have put some extra capacity on to be able to cope with that. And we're still performing relatively well compared to the rest of the NHS in these areas, but a number of areas are deteriorating. So I'll just start with emergency care. So we've obviously seen quite high demand in that area, and you know, the hypothesis is that some of this has been backlog work from lockdowns, and we'll see how that sort of progresses over the next few months. ED have been an area that have been affected by workforce supply, and it's been a real challenge for them to make sure that they can keep their wait to be seen going as best they can during that period. I think we've also been providing quite a bit of support to ambulances with Nottingham over the past few months, and that's been crucial to try and help keep them providing safe care. But obviously it creates a bit of extra demand around that. We've put about 26 extra beds in over the hospitals to try and cope with some of this extra demand, and obviously that is easing things. But we've still got about 8% of our bed base with patients who are medically safe for transfer onto ongoing care, and that is something that in the H2 capacity plan we need a real real different approach to across the ICS and remains a huge priority. And I think we're going to touch a bit on the H2 capacity plan later. But I'll pause there for any questions on emergency care.
Okay. No questions at the moment from other members of the board. Thank you for that. I recognise how challenging it is for everybody and for staff at the moment. Yes, go on, Simon.
Shall we move on to cancer?
Yeah.
Chair. Yeah. So this is an area where we're a bit disappointed really in terms of where we're at in terms of the backlog against our trajectory. So it isn't falling in line with the trajectory. Some of that is related to increased demand that's come during Q1, and there's a chart in the pack there that shows that demand, and it's quite significant in the region of hundreds of patients that have been referred into us, and record levels really. Again, some of the hypothesis around that is that it's related to sort of patients who should have been referred during lockdowns, who weren't for obvious reasons, and we'll see how that translates over time. So we are going to, based on the demand we're seeing, we are going to reforecast what we think might happen to the cancer backlog. We've also seen, certainly during the last month, that obviously Nottingham have been severely challenged in terms of their ability to support patients as of with regards to critical care. And that is having an impact in some areas around cancer, but we're doing everything that can be done to mitigate that at the moment. We've got a lot of work going on in this area, not least at the end of this month we have an endoscopy expansion which will treat about another 150 endoscopy patients per month, and that will really help. And we have the lower GI plan that we brought to board, I think, the month before last, which is rolling out, and I'll bring an update on that next month. But I think the risks continue in this area around demand. We have a harm review process and a risk assessment process for patients who've got long waits in this area. We do continue to do well on the faster diagnosis standards. So I think about 80% of our patients are sort of get a diagnosis within 28 days. But I think the concern is where there's patients who don't get under that 28-day barrier and how long they wait for their diagnosis, and a lot of this is in lower GI, so there's still a lot of work to do in that area. But we'll bring a reforecast back through board next month for a further discussion. Again, our position nationally is improving in this area, but that's sort of cold comfort really, because this is really about the actual number of patients that are waiting. I'll pause there for any questions on cancer.
And perhaps I can just ask you, in terms of the additional resources that we brought in for diagnostics, you know, how do we feel that they are working at the moment to support? Where would we be without them, I suppose, in essence?
Well, we will be in the worst position. I couldn't quantify that for you, Chair, at this time, but yeah, I mean, we've brought extra CT capacity, which has really helped. I think we've still got a bit of work to do with that around CT colon capacity, which is a really increasing use of diagnostic in the GI cancer pathway. So we've still got a bit of work to do there with regard to CT, but I think endoscopy coming on stream will help that even further. And I think some of the things that the divisions have done really well and clinicians have really supported the tightening up on is around some of the admin processes, you know, and that's really helped patients at least get clarity on you know, whether they have got cancer or not in a much quicker timescale against the FDS. But we've long reported that we are at diagnostic deficit in terms of our radiology capacity, and obviously we've got a strategy in place, but it won't be quick to try and bring some of that to try and improve some of the capacity in that area. And we're continuing to treat more cancer patients than ever, really, which is, you know, while some of there might be some waits over 62 days, you know, the mean is relatively stable in that, and it's very positive that we're treating more patients. I noticed Amanda Pritchard, who's the new chief executive of NHS England, her first sort of formal communication was about referring more patients into hospitals for risk of cancer, and so that's a really good thing. So we welcome these referrals, and we continue to try and build the capacity to be able to treat those patients in as timely manner as possible.
Thank you. I've got a question from Andy.
Thanks, Claire. Simon, really clear and helpful update. Probably isn't, but I just wondered where we are with long screening. Is that adding any pressure? Because we discussed in a previous board about we hadn't seen this blip in referrals, where some places had. It now looks as though we are seeing it. So is it just pent up demand, or are there local initiatives that were set out with good intention but are perhaps adding to the pressures?
So we haven't seen any material increase in referrals in for lung cancer. I think a lot of the growth is in GI. But we'll continue to monitor that, and I think that it probably will increase over time, which is, you know, part of the whole point of this of the screening programme. I think there's a bit more work to do in that area, because obviously respiratory medicine are extremely pressurised in other areas of their workload, and there's still a bit of recruitment to go on in that specialty to be able to cope with forecast increases in lung. But we welcome those referrals if they're coming through the screening programmes.
Okay, thank you.
And then there's an update later on around the elective waiting list, but in terms of the activity levels, we were at 96% of our 19-20 activity, which, given where we've given the sort of infection control precautions that everyone's having to take due to COVID, is good to see again. And it's been broadly at that level for a few months now, so perhaps finding a bit of a stable level. Inpatient, there's an exception report on inpatients, and that was lower, that was in the 60s, but that isn't representative of the activity going through theatres. It's just representative of different levels of coding. So theatres are doing as much activity broadly as they were doing in 1920. But a higher proportion of that work is non-elective work, so emergency work related to the increases in demand that surgery and particularly orthopaedics have seen. And also there's been a significant conversion to day case going through theatres, which is really positive to do. And then obviously the surging of critical care impacts on the inpatient work more than anything else. So I think that overall the activity position remains relatively good, and some of that is obviously helped by the accelerator. There is a cashing up process that's going on at the moment across the ICS, because the accelerator was an ICS total thing to see where we will land against 120%, and we can report that to board next month. Although obviously Nottingham have also seen a big impact during COVID on their ability to do activity during this period.
Thank you, Simon. Very helpful.
Got anything else to raise, Claire, unless there's any other questions?
I don't think there's any other questions.
Okay.
Thanks, Simon. We'll go to Paul, who's Deputy Chief Exec and Chief Financial Officer for Best Value Care, and then Emma's just going to give an update around financial improvement.
Thank you, Richard. And can I just introduce Richard Mills, who's joining the board as Acting Chief Financial Officer from next month. Richard's joining the board today in an observation capacity. I'm sure he can answer some of the more tricky questions should they arise. And Emma, I'll offer you the opportunity to introduce the FIT programme's contribution to the financial position that I'm just about to talk to. So the month for financial position, this is the end of July numbers within the H1. That's the plan for the first 6 months of the year. Our deficit in month is 100,000, and that is slightly worse than a break-even plan. Our year-to-date deficit, however, of 200,000 is better than our plan by 1.2 million. We had a 1.4 million deficit planned for month 4. The July expenditure includes direct COVID expenditure of 900,000, and that's an increase of about 150,000 on the previous month. However, much lower totals of expenditure than we've experienced in previous waves. We're recording vaccination expenditure of 2.4 million, all fully recovered through the income streams associated with that. And we have received elective recovery fund income of 3.9 million a year to date. In terms of forecast, it's this area that's causing a risk in our forecast position for H1. There were changes announced nationally to the elective recovery fund thresholds to take place in Q2, so from the 1st of July, which mean that we will receive £2.9 million less elective recovery fund income than we expected to, and we think that that results in a £1.3 million overall deficit forecast now for the H1 period. We're currently discussing with NHSEI what that means in terms of whether that carries the impact into H2, and that is unclear at the moment. In terms of capital, we've experienced delays in our significant programme areas of ED Resus and indeed Mansfield Community Hospital schemes, and that has led to an expenditure position of 700,000 year to date, which is 600,000 less than we planned. And in terms of cash, our closing cash position at the end of July was £3.9 million, and that's £7.5 million lower than plan. And that's due to delays in receipt of ERF and COVID vaccination income. That income's now been received during August. So I'm happy to take any questions at this point, or happy to hand over to Emma straight away.
Okay, we don't have any questions at the moment, so let's take Emma while we see.
Thank you, Chair. Thank you, Paul. So our transformation and efficiency delivery at month 4 remains in a positive start as we did at the beginning of the year. At month 4, our plan was to deliver 2.4 million efficiencies, and we're actually at month 4 delivering just over 2.8 million efficiencies. So what that means is we're over £400,000 above plan of what we plan to deliver up to month 4 at this point. We continue to work closely from a Sherwood perspective, but also understanding what's happening at a system perspective and nationally, which Paul's just alluded to with regards to the elective recovery fund income, and if there is any impact on our plan moving into H2 onwards. But the outlook is at this point we are positive and remain above plan in delivering our efficiencies as an organisation. Thank you.
Thank you. Richard, can I just say, Richard Mills, that is. It's going to get less complicated from next month, isn't it? Because there'll only be one Richard. Sorry about that, Richard Mitchell, but welcome to your first board, really, is an observer and getting an opportunity to see what we're doing, and we look forward to seeing you in place as the acting Chief Financial Officer next month.
Thank you, Claire.
Thank you. We don't have any questions, so thank you very much for the comprehensive report there, Paul. Back to you, Richard Mitchell, for anything else you want to add.
No, nothing more from me. Thank you.
Great. Thank you. OK, so moving on to committee terms of reference. Shirley.
Thank you, Claire. This is just to seek board's approval of amended terms of reference. So back in August, the Quality Committee terms of reference were amended, and at that point it seemed prudent to make the quoracy of all the committees the same across all board committees. So the quoracy is now there for board to see. The agenda template has also been amended so that chairs of the committees can quickly check the quoracy when they start their meeting. So it's just here for board approval, please.
Excellent. Can I ask board members to indicate their approval in the chat room, please? Okay, those are coming in. Thank you very much, Shirley.
Thank you. Thank you.
Over to our outstanding service. Hopefully we've been joined by those who are giving any presentation on the HSJ Partnership Award finalists.
It's a video this week, Claire.
Is it? Okay, thank you.
Just bear with me a second.
So I'm Helena Clements. I am a consultant paediatrician and clinical lead for the climate action team here. I think I'd like to add that I'm a mother and a grandmother as well, because I think that's really important and significant. So the climate action project team has really grown organically over time. So I've been thinking about this in my personal life for more than 20 years, but it really came to a sort of a natural progression into the trust 2 or 3 years ago, and I started to talk to my colleagues. I've been teaching medical students, paediatricians, and then talking to the executive team as I've been clinical chair, and I've been supported by all of those people to keep thinking about it and talking about it. And then a couple of years ago, Richard agreed that I could be the climate lead, to give me some authority kind of to take this forward. And as soon as that happened, actually people started to contact me and get involved, and this is very much individuals coming from every part of the hospital, which has been fantastic. So climate action is about every bit of everything we do at Sherwood, taking into account the climate emergency and acknowledging that the climate emergency is a health emergency, and reducing the carbon footprint of the health service is a really important part of that. And we've been doing that for the last couple of years, and in fact the government has really taken that forward in the last 12 months as well. So that's what it's about. Everything we do in this building, in this trust, and beyond is what this is about. The Hope Orchard is something that I was thinking about. How do we come out of COVID and have hope? And I was thinking, I use trees as a symbol for births, marriages, deaths, weddings, you know, in my own personal giving, if you like. So as we came out of the second wave of COVID earlier this year, I wanted something that was about the future and about hope, rather than about the awfulness of COVID, really. And that's where the word hope came from in my head. And planting trees seemed a really good symbol of that. And again, linking trees and the importance of trees and the environment to health and food, because food is really important. All of that really sort of fitted together in this Hope Orchard, and then making it more than just Sherwood but a community initiative. Again, it seemed so obvious to me as a paediatrician that we needed to make this ICS wide, county wide, and beyond. Being shortlisted is huge for me and for the rest of the team, I think, because they've carried on with that despite all of the stuff that's happened to them personally through COVID, and so I'm really pleased. And as somebody who's been talking about climate for quite a while, this is just another opportunity to spread that word wider. So it ticks all my boxes. It's wonderful. I hope people will vote for us. I think the concept of health being the whole of the NHS being part of the anchor community for the UK, and health and climate being absolutely interlinked. If we can achieve that through this awards ceremony, then we've succeeded in something really big, and we have to take it forward.
Hi, I'm Emma Challens, the Director of Culture and Improvement at Sherwood Forest Hospitals and Chair for Proud to be Ops. So Proud to be Ops has been recognised nationally for its outstanding contribution to workforce and healthcare as a whole. And the way it's done that is that we've created an operational network for managers and leaders across the country where they can get together to connect, to learn, to share and develop themselves as ops managers and leaders. So it's important for Sherwood Forest Hospitals to host the network because we are an organisation that has invested quite a lot in our leaders, recognising people, and that people feel that they belong to a profession, to a workforce, to the system and an organisation. And that's why it's important for Sherwood that we continue the aspirations of the Proud to be Ops network. I believe that the Health Service Journal Awards has recognised us because we are innovative and we are different. We have shown such spread and growth over the last 12-18 months particularly. I think we've shown that actually we're able to create safe, supportive spaces for leaders, and we've done that based on our principles and values and based on people rather than performance and plans. And that's really stood out, and we've been able to have some difficult conversations, whether it be about equality, diversity, whether it be about well-being and recovering and how do leaders lead their workforce, and that's different. And I think that trust that we now have as a network has really been recognised. One of the things that really stands out to me being proud about is this year we launched the first Executive Director programme for a Chief Operating Officer, and the network shaped and designed that Exec Director programme. One didn't exist before. Many other exec programmes existed for finance, HR, nursing, but never for ops. And I'm really proud that we've been able to get that forward, and I think again that just shows our role as a network and the skills and insight that we can give to developing such longer term plans for health and care. So what would I say to all of our members? I think 1, be proud of what you've achieved together. 2, spread the word and celebrate the role of ops, the importance of ops, and how you want to recognise what people do every day in these important roles. And I think enjoy it, have fun. Those who are attending or watching, recognise your achievements and celebrate everything that you do. Really proud of every ops manager and leader and colleague across Sherwood and the whole of health and care.
Excellent. Really positive and inspirational presentation there, I think, from 2 of our leaders here in the community, both Emma and Helena. And hopefully we will see the outcome of more of that investment in our staff and in those services over years to come, whatever the external recognition of that we'll see the value certainly here at Sherwood Forest. So thank you to both of those. Richard, you wanted to comment on any of that?
No, just reflecting. Obviously, if we sort of go back to the soft, clearly, as we all know, the core business of the organisation is providing safe care to people. And as you were describing, Chair, I think it's really impressive, whether it's through the climate action or a key member of Proud to be Ops or many of the other things that we're doing, that we're able to focus on the core business, but also play a meaningful role in changing the lives of the people that we work with in the wider community. So best of luck to Helena and the team and to Emma and the team. And as you say, if we win, fantastic. If we don't, it's not through a lack of trying.
Great, thank you very much. Okay, we are looking now at just what the communications will be to the wider organisation, and obviously picking up on the last presentation, I think would be an important one of those to reflect how important we see, from the board's perspective, we see those 2 initiatives. I think we had a really good report on flu vaccination and what's going on there. but also on the occupational health and guardian of safe working. I think those were 3 reports that we might want to highlight. Lorna, anything else?
I thought it might be worth highlighting the strategic priorities for H2 that we've agreed, and also to support the work that we're doing to ask people to update their ESR so that we can start to get a little bit more data around diversity that we talked about.
Excellent.
Oh, and Hayley as the exec lead for what is now the PBP.
Okay, great with those. Richard?
So from that last point, yeah, it's not yet PBP, so
Okay.
it will
Stick
be
to ICP.
ICP for now.
Okay, for the moment. Okay, fine. Thank you for that. Any other business? I've certainly not been informed of any other business. The date of the next meeting will be the 7th of October. I would like, therefore, to thank everyone for attending, particularly referencing once again our thanks to Richard Mitchell, as this is his last board meeting, and to read out the statement that I'm required to read. In accordance with Section 1(2) of the Public Bodies Admissions to Meetings Act 1960, members of the board are invited to resolve that representatives of the press and other members of the public be excluded from the remainder of the meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. So I'll ask colleagues, therefore, to return for our part 2 private board meeting. Perhaps we can return at 12:20, so a little bit earlier. We can start if that's okay. Thank you very much, and I officially declare the meeting closed.